So we have two more talks before we move tomorrow to spinal. So this is a special group of disease that was explained by embryology and anatomy. It is called Parachordal AVF fistula. In this situation, there are two levels, which is the branchial and the spinal level. So I'm gonna talk both to compare between the external carotid in adult and the vertebral arterial fistula in adult. So why we have these two consecutive levels similar? Because the embryo center of this malformation is the notochord. And the notochord ends at basic sphenoid level, at the junction of somatic branchial and the prebranchial somatic part. The rostral end of notochord is at the cavernous plexus, which, for example, the arterial supply that level is maxillary artery. Also, the extradural internal carotid artery. And caudally along the notochord are all segmental arteries. Neurocrest and mesoderm development of segmental vascularization. As the artery of craniovertebral junction, you already talked a lot this week, as well as along the segmental of each level. So if we look the relationship between the segmental arteries and veins, we have at the cranial level, for example, this maxillary acetylpharyngeal occipital artery, related mostly with the regional jugular veins and the vertebral veins. So while downwards at the cervical level, we have each segmental artery down to thoracic level, this kind of relationship, mostly with acetylcholine system, as well as later on vena cava system. So this shunt will be seen, for example, maxillary to external jugular vein, maxillary artery to external jugular vein, acetylpharyngeal to jugular vein, occipital C1, C2 to the vertebral venous plexus or posterior jugular veins. We can see at the thyrocostal vertebral level, and I told you we include the C1 segment of internal carotid artery. Why in the somatic downward level you can have the vertebral artery to veins and as well as the intersegmental channels. Where the brain drains, there could be to the low resistant internal jugular vein and acetylcholine vein, but it can also drain to the higher resistant of the posterior external jugular vein, vertebral vein, and other epidural venous plexus. So the direction can be the centrifugal drainage, as I told you, and as well as some rare centripetal drainage into the cerebropyral root radicular veins, as well as the epidural drainage into the cranial sinus venous plexus. How about the symptoms? Usually this type of the fistulas mostly have no symptoms or very mild, such as paucitiveness or bruit hurt by the children, by the mother, or by the physicist who take examination. There could be a very, very young patient, the systemic of congestive heart failure can occur. And when the venous pouch getting higher, bigger, it can cause compression to this kind of nerve root or the cord itself. As I told you, there can be retrograde prior venous congestion. Remember this if you have some associated disease, for example, the metabolic disease, that can also be the presentation. Pierre was putting this into his book in the group of epidural and paraspinal in the cephalic and somatic levels, and we don't see much in younger child. We see in the grown child and young adults mostly. We start the example of the cranial or branchial arteriovenous shunt, where the arteries responsible is starting from the C1 segment of the cervical internal carotid. Before we have some example of parietal, hypoglossal, and stapedial artery. For sure, the maxillary or stapedial system and pharyngeal hypoglossal system will be shown. You can see when you have these kind of non-invasive imaging how close to each other between this enlarged artery and very large veins that connected to each other. We have this boy presented actually with mild right chemosis and exophthalmos. This is catheter was put in internal carotid artery. What do you say? You say for sure large internal carotid kinking, and you see rapidly filling up the veins, and you have something going up above here. So it seems to be the continuation of internal carotid artery. You see later on this type of venous drainage, and you can see finally when the reflux of the venous drainage go reaching the cornea sinus, you can have the presentation of superior-ophthalmic veins and becoming the presentation of this child. Actually, the bruit was heard by the physician. And we call this as the extradural internal carotid artery ruptured into the jugular veins. You see how abrupt change of the caliber of the proximal and distal to fistula can be seen. It's very classic to see that. Well, we were very good in using detachable balloons, which sadly we don't have for now. I hope that the company will come back with the detachable balloons next year. I'm not sure, but by the time we were putting this, we see precisely where is the shunt always by putting the catheter in all the possible collateral artery. For example, this is to use the pincum, sucking down and see nicely how the carotid opened into the veins, and now you know exactly where to put the embolic material. In this situation, we use one detachable balloon, and this is the result. You have now closing up all the fistula, giving a very nice continuation of the internal carotid artery and normal veins drainage. So, apologize for the old fashion type of images, but this is the one that presented with subarachnoid and intraventricular hemorrhage. And then they inject internal carotid artery again, very tortuous kinking. They saw immediately the veins draining up again at the same pattern. And for this, not only the ophthalmic veins, but they have a lot of pile reflux. And this could again presented with the hemorrhage intracranially. They were using the same embolic material as us, and they were able to close these fistulas. Now we move to one of the most common. I say that it's in the branchial level. Is most common is the maxillary artery, arterial fistulas. And again, the bruit can be here at the area of parotid or rectal, around the auricular area. That the bruit can be seen, and there are rare cardiac symptoms. And usually the maxillary artery opening to the maxillary veins or the external veins. It can reflect also to the cavernous brain and depends on the time of the cavernous sinus captured. This kind of very large artery opening to the very large veins, you can have hard time to identify, but one of the clues to identify where is the fistula is you can sometimes see the normal branch in the very normal size coming off So that is one of the marker to see that actually if you put embolic material actually at the junction of artery to the veins, you can now see how continuation of the change of size of the caliber as well as other normal artery. And this is the one that they put the catheter quite high up in the maxillary artery. You see again the abrupt change of the caliber to the normal branch and the rapid shunt going down to the jugular veins. And now you can have the embolic matter block at the junction of the distal artery to the proximal vein. We were having this grown-up man with this kind of, you see this maxillary injection open up with a little kink vessels there, and finally you see that this is for sure the draining veins at that level. We see a little branch coming off in the normal size. So in this situation, because I saw that there is a kind of narrowing of the area of venous drainage. So that is one of the clues that you can choose embolic material that you want, because you have a kind of safety by have a very tight narrowing at the venous level. I was seeing that. So this is a normal size branch. So we go up, and I was trying for sure to put the last part of this segment of narrowing proximal and distal for sure that my glue is not escaping from that. And even we didn't use the glue backing up much. This is immediate control angiogram. For sure you have some kind of stagnation. And this is how the MRI will be seen as a thrombus part of the lesion, and normal venous drainage or the fistula can be seen. Again, we just found this referred to us. It was a nice non-invasive imaging type of thing. You see clearly this is the maxillary artery opening to the large venous pouch finally draining into the jugular venous system. And this is the angiogram. They were doing this nice thing, and this is pre and post. They were putting ampullous vascular plaque a little proximal, mainly in the arterial side, and we still have some kind of slow flow stagnation into the vein, and this is the one that I will bring later on to follow up with. I need to put something else. It's in the process of follow-up. So there are multiple instruments you can play with this kind of high flow lesion treatment. We have some few examples of the ascending pharyngeal to the internal jugular vein fistulas. It's a little bit, growing up patients, and they can have for sure the lower cranial nerve impairment, because we know the function of this artery. So the fistula can be at the jugular foramen. This is the common trunk of pharyngeal occipital injection. You see that it's slightly enlarged, open up into the large veins, and by that time we were, practicing well our glue injection. We were using embolic material in this situation and having a very nice result. Another case of this one branch of enlarging branch opening up into the veins, that we were able to put coils and a drop of glue to close up the fistula opening at the junction. A larger fistula can be seen. This is non-traumatic exophthalmos and tinnitus presentation, and this is the ascending pharyngeal injection, already large, and it opened into the lobulate, large venous pouch, and open up into this kind of clival, along the clival-petrosal type into this type of cavernous sinus, having a major pyovenous reflux. And the team was able to put detachable balloons, I think 2 or 3, into this pouch, and were able to get close up all the fistulas. And this is the control post-embolization. There's a nice case from Insup. He was just to complete my group of disease by giving me a very nice case of this girl presenting with paucitinase and bruit detected by the mother. And you see by non-invasive imaging that you have these well-correlated enlarged this occipital artery open up. You have hard time to see where is the shunt, but finally, when you do the selective injection, and during the put microcatheter through this one curve, two curve, you see that the opening up to the vein is around this area. It's a suboccipital venous plexus that is dilated, and then I think he was put in coils, and we were able to have a very nice result. When we go down to the somatic levels, we are talking about paraspinal epidural site of fistula. And examples start with the vertebral artery, segmental artery. This paraspinal one will be taught mostly by Carl in the spinal section, but just to add some few images here that it's a paraspinal location shunt, and the bruit can be there, congestive heart failure in a young patient can be there, treatment can be transarterial with a lot of coils to occlude the shunt. In our own case, we have this epidural shunt open up in the cervical level. You see this young man presented with this venous pouch compressing both the spinal cord and nerve root. And you see by an angiogram that these show the vertebral, contralateral vertebral. This is the area that the non-invasive imaging pointed to us, that we have a big opening to the veins here at the epidural levels of the shunt with a gigantic enlargement of the veins over there, making the bad symptoms. And with this situation, you can choose also to close up this shunt. We were able to put 2 or 3 catheters to make sure that the glue injection were enough to make some stagnation in the post-embolic images, which finally we were having no more further venous drainage seen, and this is few months follow-up angiogram that we see no more shunt and the collapse of the venous pouch that used to compress the cord. In many situations, you may need to go transvenous, and this is not an easy procedure because each level of the venous pouch needs to be packed and to control whether the shunt is still there. So if we talk about vertebral arterial fistula, we have a big group of disease that the upper group, between C1 to 3, we are still related C1, C2 to the pro-atlantal system. There are role of occipital artery contribution, and the drainage are mostly, as I told you, suboccipital and vertebral veins. And we may have to check also this type of vessels, but for sure in the lower group, we have more related to this type of large dural lake, and for sure all these cervical artery need to be checked, and most of the lower group are related to collagen vascular disease. So upper group are mostly pediatric and non-collagen vascular disease, and lower group are older age with collagen vascular disease. They are mixed group that we see in our life. Some may related to metabolic disease, for example, SAMS, and some may related to trauma. So make sure that you have now talking in a big group of things that people mix up with things. Clinical presentation can relate mainly to the venous drainage. You can have epidural shunt with this type of epidural paraspinal drainage. You can have the ectatic intradural pouch. You can have the intersegmental ascleral drainage. Depends on the location. So clinical manifestations are related to large venous leg, compressed cord, progressive myelopathy. So when they have some retrograde reflux, you can have the megalani symptoms. For example, this one that comes from the Pierce book, saying that this subarachnoid intraventricular hemorrhage in these, abnormal ventral perimeter veins located there. And when you inject vertebral artery, you have rupture of the C1 segment of the vertebral artery into the mostly the paravertebral epidural veins, but you see also this kind of intradural venous reflux going up there. So the possibility of intradural presentation, including in the higher cervical level, the hemorrhage can occur. We report this case a few years ago with this vertebral injection opened up into the veins at the base gout and presented with this type of chemosis exophthalmos. And for sure there are also the pyovenous reflux that can be seen. And so the vertebral fistula at this level, the shunt can be seen there going up, not only going down. So the angiographic protocol, we highly recommend you, as we know that you should inject for sure ipsilateral contralateral vertebral artery in the upper part, ipsilateral ascending pharyngeal occipital system. In the mid-lower part, you need again ipsilateral contralateral vertebral or ipsilateral cervical artery need to be checked. Must pass minus the upper thoracic segmental artery. This is the upper cervical segment. We have this boy presenting with the learning problem and quiet personality. The thrill was hurt. So we do this, and you see from ipsilateral vertebral, AP lateral, and contralateral vertebral injection, for sure you see that the fistula is there. But this is the role that you should, for sure, ipsilateral pharyngo-occipital injection. You see the contribution of C1, C2, probably C3 contribute to this kind of high flow fistula, that you can mark well the exact location of the fistula. We were putting a detachable balloon nicely here to completely close up the fistula. Very nice case from INSUP at the C3 level location of the fistula. This is the row of segmental artery at C3 segment. You see that the very big pouch with the fistula located there, and he did nice AP lateral in all phases, including contralateral vertebral artery, seeing the vertebral artery coming down, filling up this same nice location of the fistula, and also inject the ipsilateral cervical arteries to make sure that the contribution can be seen or not from that. I was able to close up the fistula with this most of the course. So when we have this high flow fistula, for sure we want to complete closure, but it's not easy. It's not like the carotid cavernous fistula that we have higher chance of complete closure of fistula with preservation of the parent artery. In vertebral fistula, you have less chance to preserve the parent artery, but even for that, you need to make sure, mostly we do bilateral approach, femoral artery, to make sure that you feel that you completely close the thing, and the other side you need to check immediately whether you have completely closed proximal, distal, or part of the fistula. So this kind of thing can be seen. You have all the stealing up from the contralateral vertebral open into the fistula over there, and this type, I think, is Carl's case, that he even tried me to go to this contralateral side to be able to treat completely this type of closure of the fistula. And for this case, we need to close up the vertebral artery of that side. People call this reverse vaginal artery flow, that you have no supply of the peripheral circulation from this evidence of vertebral injection, but the vertebral artery are filling up well if you have the very nice posterior communicating artery for sure. And if you were able to close up the thing, this reversible may change. I will show you that we have, even in this type of fistulas, in this lower down level of the vertebral artery. This is a little bit adult type, 20 years old, with this fistula seen from the non-invasive imaging. You see this gigantic venous pouch from ipsilateral and contralateral vertebral injection. You are having this nice one single detachable balloons or coils or whatever you have to close up and preserve this vertebral artery. This is one of the less percentage that we can preserve this. For sure, you need to make sure that you have quite long-term follow-up. This case, we have 1 year follow-up, and there is no more opening, and the symptoms actually improve. 19 years old man presenting with right arm weakness for 6 month history of minor trauma. My trauma is not very significant. We have this large pouch compressing this spinal cord level, and we were seeing that high flow from the ipsilateral vertebral, making this nice see that when we were able, you see the significant difference in size of the vertebral artery, proximal and distal. This is the detachable balloons we put to make sure that we close up the thing, and we still have a preservation of the distal vertebral artery, helping to supply at least the pica of the right side. And on the lower down, for example, this a lady with this type of numbness of the hand, you may misdiagnose as the local symptoms of the hand, arms. But think about this: if you cannot solve the problem there, think about it. It's a possibility to investigate and have this type of fistulas that open up in that level. And you will see that if you were able to close up these gigantic fistulas, you were able to reconstitute again back the vertebral artery, helping to supply the posterior fossa. And for sure, the follow-up will be a collapse of the venous into a thin thrombosed pouch, no more compressing to the cord or nerve root. Young girl, you may have this carotid bleed when you put a stethoscope down in the neck area, and this is a fistula that was seen at the C7 space level. And this time we were putting nice coils. Even we see a little anatomical variation that the persistent channel was there. So just make sure you understand we are talking about a group of disease, the so-called vertebral fistula. We talk already parachordal fistula, that maybe there is congenital defects, and it's open up directly from the artery of the region, branchial and the somatic level. And it could be part of metabolic alterations. It could have the trauma trigger. It can have the collagen vascular disease. Nice case from Carl that showed these paraspinal pouches and intradural venous vessels could related to this skin cutaneous malformation in the same metabolic levels. and this could be related to spinal artery venous metabolic level 1, 2. Sometimes you have the 2 levels compared to each other. We were having this post-operative one that has, finally a bruised hurt at the lower neck, and very nice non-invasive imaging showing this vertebral artery opening into the veins. And this is what we see at this level. In the chronic case, you can have all of the collaterals, even the midline collateral, or the side cervical arteries coming open up. And this is one of what we call, reversible thing, because all the anterior circulation needs to come for help to supply for this posterior circulation. And when we were able to make sure that we close up the fistula, this preservation of the parent artery, finally come up with the supply to the posterior circulation if we were able to make it. Last few cases concerning collagen disease, we have major 3. One, I believe that the one related to this type of disease could be either of them, but I will show neurofibromatosis because we have a lot of examples. The others are for sure one of the most dangerous, easy to rupture of artery into the veins, and as well as irregular aneurysm, multiple aneurysm type of fibromuscular dysplasia. But for this VVF, we mostly talk about the NF. And we can see that there are manifestations of the NF in this area of the disease, including this. We have this patient with clinical classical leaf. And all of our NF related with VVF, we have all these scoliosis, kyphoid, lordotic curve, every single patient. So the skeleton change are very classic also for this type of patient. So you will see that he comes with a pulsatile tinnitus, and we were able to see the gigantic opening venous pouch over there, and this is what he has in this vertebral, right vertebral artery injection. And we were able to put the embolic material, trying to be able, but we will not be able to save the vertebral artery. In this collagen vascular disease, try not to manipulate things too much, because you know that the vascular wall is not normal. I will not try to do a fancy or stent into this type of patients. Gigantic venous pouch can be seen. We have this from Sri Lanka group that she has treated this gigantic pouched mass at the region, and look at the angiographic tortuosity of the artery, gigantic venous pouch, huge. This contralateral, look at the arterial irregularity, kinking. They were able to set multiple sessions of embolization, and finally they were able to close up the fistula. Our current case, very classic type that you have this again scoliosis kyphoid type of a patient, known NF with a nice mass at the paravertebral area. They were misunderstood a neurofibroma or whatever the mass that was there and was setting for the excision of the mass. Sure, they got a little uncontrolled bleeding from the side, so they try to pack, and they now start to do vascular imaging. And now we were able to see that it seems that there was slightly big vascular pouch, partially thrombosed by the area, and there was a little veins drainage out already from that pouch. And this is the angiogram that was shown after attempt of some surgery. And so we were able to use multiple instruments, including balloons, coils, and finally glue, to be able to close up this. Again, by finger approach, and then trying to make sure that you complete quickly close up by checking contralateral vertebral artery. So some conclusion that we have seen a lot of parachordal arterial shunt. We have indication for treatment in all symptomatic case. We have gigantic venous pouch usually presented with the mass effect. And we want curative result if possible, if not the disconnecting or decreased pyrovenous reflux method. We still discuss whether endovascular surgically, but in terms of endovascular treatment, we have a lot of embolic materials to choose. As I told you, for the vertebral artery, it's the less population that we can preserve, the parent artery. Role of segmental arteries are very important. We try to check all the possibility of collateral circulation. And remember, we are talking about big basket in the vertebral level. So most of the parachordal one will be in the upper 2 levels of the vertebral artery. And that's it. Thank you.